Our next speaker is Corrin Coons. She is actually one of my nutritionists at the hospital. Some of you actually may have seen her when you had your surgery, or for those of you who might be having surgery, we'll meet her. And her topic is a little bit different. So you've heard great tips for everyday types of things for nutrition. Hers is a little bit different. I wanted her to talk just a tiny bit about advanced nutritional supplementation, which hopefully none of you will need, but some of you might. And the reason I bring it up is, and Carolyn can speak to this, is that her husband required very advanced nutrition to survive. And so sometimes these are things that we might have to kind of pull out of the toolbox in order to help. They're mostly hospital-based, but it's just something that you should be aware of. So, Corrin, come on in. All right, everyone.
Yes, hi everyone. I'm very grateful to be here with Dr. Lou, and I'm an inpatient dietitian at Presbyterian St. Luke's. So I work with Dr. Lou's patients while they are admitted to the hospital. So today I will be going over the role of inpatient dietitians in supporting patients with neuroendocrine cancer. Next slide. So I'll be going over malnutrition in neuroendocrine cancer, and then what we can do to help implement interventions to prevent and correct malnutrition if it is occurring. So starting off, as many of you may be aware, there are many challenges that patients with neuroendocrine cancer face in being able to get adequate nutrition. So this can include poor oral intake or food by mouth, malabsorption, like Leanne talked about extensively, and also just an increased metabolic need in general. So as you can see quoted here, up to 40% of patients with this cancer can have malnutrition. And of course, this varies from study to study, but it just shows how much this cancer can really impact the ability to have adequate nutrition. Next slide. So starting with causes of poor oral intake, this can happen for a variety of reasons. Loss of appetite just from the cancer itself, a side effect from medications, fatigue, whatever it might be, can just prevent you from wanting to eat food in general. And then GI symptoms, which Leanne discussed extensively, diarrhea, abdominal distension, or fluid buildup in the abdominal cavity can occur quite commonly, and those can obviously prevent someone from being able to eat enough by mouth. And then small bowel obstructions, like Leanne mentioned, can be common either from the cancer itself or from scar tissue from surgery. And then kind of similarly, an ileus can occur after surgery, which is just a temporary lack of ability for the intestine to kind of move and function. So both of those can cause periods of time with little to no nutrition by mouth. And all of these together can contribute to food fears and aversions, which further limit the amount of nutrition someone can get. And then even if someone is able to eat enough nutrition by mouth, malabsorption can make it harder for them to still meet those goals. So carcinoid syndrome, the somatostatin analogs can cause diarrhea leading to malabsorption. And then if different areas of the GI tract are resected, that can cause malabsorption of fat is a main one, like Leanne mentioned, and that impacts, overall energy and also can cause deficiencies in the fat-soluble vitamins, so vitamins A, D, E, and K. And then again, depending on what area is impacted, different micronutrients can be malabsorbed. So B12 is a common one, calcium, copper, iron. It just kind of depends on what area of the GI tract is impacted. So you probably won't be able to read this, but it's on the slides, but it just shows where in the GI tract each of these micronutrients is absorbed. So knowledge of what area of the GI tract is impacted, along with any clinical signs or symptoms of deficiency and potentially lab work of different levels of these nutrients can help us determine if there is a deficiency and if any supplementation is required. And then lastly, there's just an increased metabolic need for energy and protein. So from the cancer itself, treatment, surgeries, it just increases stress on the body and makes us need more nutrition just to maintain our nutrition status. Next slide. So this is just a diagram that kind of goes over everything I just talked about, and usually it's not just one thing. These individuals are experiencing many of these things, and they all kind of create an additive effect and all contribute to malnutrition in their own way. Next slide. So why do we care so much about identifying and preventing or correcting malnutrition? Studies have found that malnutrition can lead to a decline in functional status, so less energy, less muscle mass, can increase treatment-related complications, cause a longer stay at the hospital, and just an overall worse prognosis. So it's really important for us to be able to identify malnutrition and then implement interventions that can help prevent it. So now I'll kind of talk about how we do that on the inpatient side. So similar to other healthcare providers, we follow screening, assessment, diagnosis, and then we implement our interventions, and then do a lot of monitoring to kind of see how those are doing. So our screening process starts with the malnutrition screening tool, which is just a questionnaire that is asked to any patient when they're admitted to the hospital. It asks about food intake and weight loss, and if you score a 2 or higher, we are triggered to go see that patient. And then another reason we might go see someone is if we get a consult from another healthcare provider, or also we check in with any patient after 7 days just to kind of see how things are going with eating. And then when we do go see someone, the information that we are collecting in our assessment includes a diet history. So how has someone been eating? Have they been eating less, and over what time period? What foods are they tolerating? And then we also collect a weight history. So what is their usual body weight? Have they lost any weight, and over what time period? And then any GI symptoms they might be experiencing. We look at the medications they're on, any lab values we have, and then we also do what's called a nutrition-focused physical exam that just looks for stores of muscle and fat and for any signs of, like visible signs of micronutrient deficiency. So that's all kind of part of our assessment. And then we take that information and we develop a nutrition diagnosis, which is basically just what is the problem, what is the main nutrition problem that this person is experiencing. And then we kind of aim our interventions at addressing whatever the root cause of that problem might be. So next slide. So if we do diagnose malnutrition, we use the Academy of Nutrition and Dietetics and American Society for Parenteral and Enteral Nutrition's guidelines for diagnosis. So to diagnose someone with malnutrition, they just need 2 out of these 6 categories. So reduced energy intake, weight loss, a reduction in muscle mass or body fat, fluid accumulation, or a decline in their functional status. And that can help us diagnose malnutrition and make sure it's addressed. And you can't read this again, it's in the slides, but it just shows what areas of the body we look at for either fat or muscle loss and what might constitute mild, moderate, or severe depletion. So now, like I said, we take all of that and use that information to help come up with a diagnosis, and then we implement our intervention based off of that. So the first line is always the oral route. We want you eating by mouth if you can. So this has already kind of been talked about a little bit, but high protein, high calorie diet, there's different equations we use based off of weight to kind of estimate how much calories and protein somebody might need in order to maintain their nutrition. And then, like Leanne mentioned, small frequent meals. So when someone's in the hospital, we really encourage them to eat kind of going more off of like a timer rather than their own hunger or anything like that, just to kind of get in more nutrition in small amounts throughout the day. If someone is not hungry or they're having GI symptoms, it can be really hard to get in enough nutrition with just 3 meals. And then limiting trigger foods like Leanne touched on, high fat, high sugar, spices, things like that. And again, it's very individualized, so using something like a food journal to kind of track what you're eating and your symptoms. And then oral nutrition supplements, so kind of like what we have from Kate Farms in the back, just those protein shakes that come pre-packaged. We use these a lot in the hospital. We can go ask patients, what flavors they like and schedule them to come up automatically so they don't need to even think about it. It will just be delivered to their hospital room at certain times throughout the day for them to have. And these are just great because they're really energy dense and pack in protein too in just a small volume. So it can really help get, the most bang out of your buck for just a small little carton. And then Juven is something we use quite often at the hospital. You can get this, from Amazon and other things like that too, but we have it at PSL, and I know a lot of HCA hospitals have it, but it's just a nutrition supplement that can help with wound healing. So it has micronutrients needed for wound healing like vitamin C and zinc. And then it also has the conditionally essential amino acids, glutamine and arginine, and a compound called HMB. And this has just been found to help with wound healing, whether it's a very large incisional wound or someone has pressure injuries from, immobility and laying in bed all the time, or even just someone doesn't have wounds. It's been found to help prevent muscle loss and help maintain weight. So we use that. It's recommended to drink it like twice a day, and there's different flavors that kind of just taste like orange juice or like fruit punch, or you can just mix it into other foods if you don't like the taste. And then pancreatic enzymes, Leanne kind of already touched on if someone is malabsorbing fat, trying to take those capsules at meal times. And then if we identify any micronutrients that are deficient, we can implement supplementation for that. And then I won't go too much into this because Leanne already kind of talked about it, but specifically if someone is experiencing carcinoid syndrome, recommending a low amine diet. And again, that's very individualized. And then one thing with carcinoid syndrome in terms of kind of vitamins, tryptophan is an amino acid found in proteins, and it's used to make both serotonin and the B vitamin niacin. So with carcinoid syndrome, with all of that excess production of serotonin, someone can become deficient in niacin since all of the tryptophan is being used for the serotonin. So sometimes we might recommend niacin supplementation if that's happening. And then again, bowel resections or GI surgery is really common. So typically right after surgery, someone is started on like a clear liquid diet, and then they'll advance to more of a full liquid diet and then kind of a soft food diet, and just really add back the fiber very slowly to prevent any obstructions or intolerances. And then if go back one slide. Just if the ileum is resected, which is the last part of the small intestine, that's the main site for vitamin B12 absorption. So sometimes supplementation might be needed kind of lifelong if a deficiency in B12 is found. And then the ileum is also responsible for reabsorbing the bile acids. So if someone is malabsorbing bile, like Leanne mentioned, cholestyramine can be used to prevent the diarrhea that can occur with that. So moving on to enteral nutrition, which is just nutrition through a tube entering the GI tract. This is kind of our second line of nutrition. So overall, this is used when someone's GI tract is functional, but they are unable to meet their nutritional needs just through the oral routes alone. So this can occur for a variety of reasons: mild nausea and vomiting, again, that abdominal distension, a poor appetite, just whatever is preventing someone from, meeting their nutrition needs, and they just need a little bit of support, but they still have a functional GI tract. And this also might be used if we need to kind of bypass the stomach. So like the main issue is in the stomach, but the rest of the GI tract is working. We can do kind of like a venting G tube that can let out the air and prevent some of those distension symptoms, and then feed kind of after that into the jejunum, which is the small intestine. So there are two main categories of tubes. We have our short-term tubes, which are nasal tubes. They go down the nose and into the GI tract, and that's used if we expect enteral nutrition to be needed for less than 4 to 6 weeks. But if we think someone will need this support for a little bit longer, like more than 4 to 6 weeks, we use just a G tube or a GJ tube that goes directly into the stomach without kind of having that nasal tube. And I just wanted to take this time to share that even if you are receiving enteral nutrition, you can eat by mouth. Sometimes that's a misconception, but even with the nasal tubes, you can still be eating while kind of using the enteral nutrition to just support whatever it is you can't do. And sometimes that can just take the stress off of eating. So someone can still eat for pleasure or, however they want to eat, but they can just use the tube to really be meeting their true needs. And then there are many different ways to deliver the enteral nutrition, and the delivery method is just decided by where the tube ends in the GI tract, and then also just lifestyle preferences or GI symptoms that someone might experience. So the most physiological method is the bolus method, which is done with a syringe or like a gravity bag, so like number 1 and 2. And that's over a quick period of time. A syringe could be like 10 to 15 minutes per feeding. The gravity bag might be a little bit longer, like 45 minutes, where it drips in a little bit slowly. But then the feedings would be like 3 or 4 times a day, much like normal eating. But if someone is having GI symptoms with that, or the tube ends directly in the small intestine where we don't recommend bolusing large volumes, then we can use a pump to deliver the nutrition more slowly over like a controlled rate. And that's done generally in the hospital when we start someone on enteral nutrition. It's always continuous with the pump, and then we might transition to either like a cycled regimen where it's 12 hours overnight so that someone can be off the pump during the day, or switch to more of like a bolus regimen to get someone ready if they are going to go home on enteral nutrition. And there are many different formula options. So we always start with like a standard formula if someone can tolerate that with intact macronutrients. But if they're having, some malabsorption, we might use what's called a semi-elemental formula, where it's just broken down a little bit to help with that digestion and absorption. And then there are plant-based options if that aligns with someone's preferences, or there's also whole food blended formulas, which are becoming increasingly popular. And these are available commercially, or patients also sometimes make them themselves. So they can just take foods, blend them up, and give that through the tube. But if someone is making that themselves, we recommend they work closely with a dietitian just to make sure they're getting the appropriate balance of different macro and micronutrients. And then there also are different forms that it comes in, like little cartons, like what you see in the top left, is typically what's used at home, and that just looks like the same as like the oral nutrition supplements that someone might use. But in the hospital, we typically use the larger 1-liter bags, which you can see in the bottom right. And that just helps save time for nursing, so they're not needing to go in and adjust it as often. So moving on to parenteral nutrition, which is nutrition outside of the GI tract. So it bypasses the GI tract and goes straight through an IV line into the veins. And we use this when the GI tract is not working, which is pretty common in this population. These tumors are all up there in the GI tract, so it can really impact the ability of the GI tract to function the way we need it to. So we use parenteral nutrition quite commonly, and listed are some examples of specific things that might cause this to be needed. So the small bowel obstructions or narrowing, like we mentioned, intractable nausea and vomiting, where you just really can't tolerate anything in the GI tract. A fistula, which is just like an abnormal opening between the GI tract and another area, like the skin, or another area of the GI tract. If that's having really high output, we need to just rest the gut and let that fistula heal, so we can use parenteral nutrition in the meantime. Also a lack of enteral access, so maybe someone is not eating very well, but we're kind of awaiting a G2 placement. We can use parenteral nutrition to really make someone's nutrition a little bit better before going through that procedure. And then severe malabsorption, like very severe diarrhea, or like short bowel syndrome, like Leanne mentioned, if so much of the GI tract is resected that it's just not able to adequately absorb things anymore. That's a situation where parenteral nutrition might be used more long-term. Next slide. So parenteral nutrition is pretty much just IV fluids with macronutrients and micronutrients and electrolytes added. So it will include all of the carbohydrates, protein, fat, a multivitamin, trace elements, and then the electrolytes, sodium, potassium, magnesium, phosphorus, calcium, and chloride that your body needs along with the fluid. So while someone is on parenteral nutrition, we do a lot of monitoring of lab values. So things like blood glucose, since we are giving, glucose directly into the veins, want to make sure that level isn't too high or too low. Triglycerides, which are just a fat in the blood. Sometimes these can be high with an overfeeding of calories, or the fat, or even dextrose can kind of raise those. So we always keep an eye on that level. And then just liver function test, since a combination of the parenteral nutrition and just a lack of stimulation of the GI tract can be kind of hard on the liver sometimes. So we just kind of keep an eye on those. But that's been improved with the use of these newer lipid emulsions that we have. It's really been helpful on the function of the liver while on this therapy. And then electrolytes we monitor very closely. When someone has had a period of time with little to no nutrition, and then we introduce nutrition again, whether it's the enteral, enteral nutrition like tube feeds, or parenteral nutrition, something called refeeding syndrome can happen, where we introduce especially the carbohydrates, and that can cause a release of insulin, which drives electrolytes like magnesium, potassium, and phosphorus into the cells, and can cause low levels in the blood. So we're always starting really slow with the calories and then kind of increase up towards goal as tolerated while watching those levels. And then parenteral nutrition comes, in IV fluids, so we're always looking at fluid status. And then we're also watching weight, again, to kind of determine fluid status, and also if someone is on parenteral nutrition long term, just to make sure they're getting the calories and the protein they need. And then when someone is on parenteral nutrition, we are always kind of watching for that gastrointestinal function to return. And if it is returning and someone is able to start eating again, we are watching their oral intake. So in the hospital, this might look like a calorie count, where someone comes in and asks you how much you were able to eat and kind of calculates the calories. And we help kind of determine that transition off of the parenteral nutrition if someone's able to eat enough by mouth. Or on the other hand, if there isn't really a return of gastrointestinal function that's going to happen quickly, we will start preparing someone to go home on parenteral nutrition, which, kind of like I mentioned with enteral nutrition, usually involves cycling it over more like 12 hours so someone can be off the pump during the day. So we're kind of getting them stable on that regimen that they'll then go home on. Next slide. So overall, it's just determining what that main problem is, and then working with the patient, the family, and the team to see what form of nutrition is really going to work best for them. And everyone's different, so it always varies patient to patient. But yeah, so these are my references. And thank you, guys.
All right, thank you, Corrin. So important.